Hi, I'm Dr. Steve Lindheim, Professor of Obstetrics and Gynecology at Wright State University, Boonshoff School of Medicine, and Director of the Division of Reproductive Endocrinology and Infertility. We have recently published a video article on fertility sterility entitled Contain Morcellation using the GelPOINT Advanced Access Platforms and 3M Steri-Drape Endobag. This comes on the heels of the safety communication that the U.S. Food and Drug Administration recently issued to healthcare providers warning against the use of laparoscopic power morcellation for fear or concern of an unsuspected uterine sarcoma or leiomyosarcoma, and the risk of metastatic spread, chances for long-term survival, and the overall quality of life. But should we jump to the conclusion that abandoning minimally invasive surgery with power morcellation is the right thing to do? Since the introduction of the first uterine handheld morcellator in 1991 and the electronic laparoscopic power morcellator in 1993, nearly half of the 400,000 inpatient hysterectomies performed every year in the United States for benign indications includes the use of laparoscopic power morcellation. Without laparoscopic power morcellation, many would be ineligible for minimally invasive surgery and deny the clear benefits of this approach. However, patient safety and avoiding and preventing harm is of absolute paramount importance. It has been advocated by the American College of Obstetricians and Gynecologists and the American Association of Gynecologic Laparoscopists that alternative treatments, including the removal of tissue through a mini laparotomy, colpotomy, and vaginal hysterectomy, should be considered, but we need to identify ways to make laparoscopic power morcellation safer. Several investigators, including ourselves, have utilized the use of endobags employing either an intracorporeal power or extracorporeal hand morcellation technique. That said, application of any new techniques can be daunting, but with a systematic approach, any surgeon can mitigate some of the intraoperative challenges for us. This video helped us identify some important elements. First, adequate incision of at least a 2.5 centimeter size is most appropriate. 2. Utilization of a large enough endobag to enable insufflation for intracorporeal power morcellation. 3. Proper folding of the endobag facilitates efficient placement of the specimen and minimizes bag tears. 4. Great care to avoid tearing the bag while manually removing the specimen during extracorporeal hand morcellation. And lastly, the technique clearly is time-consuming and challenging. However, we believe contained morcellation with sufficient training and practice outside of the operating room can still provide the benefits of minimally invasive surgery and laparoscopic power morcellation. Continued efforts to improve the technical components of this procedure will need refinement to assure that risk of tissue dissemination are minimized. We thank you for listening and encourage you to watch our video